Okay. Good morning, everyone. I am Dr. Naman Agrawal. I've done my MD in Emergency Medicine from AIIMS Delhi. And here we are today to discuss a few questions as to understand the concept of various emergency medicine aspects. Recently, a lot of questions have been asked exploring the concepts of emergency medicine in elite exams like AIIMS and other national competitive tests. So here we are, and we'll be assessing through the following 76 odd questions as to what emergency medicine is about and how do we approach a patient in the emergency department. So coming up first is a scenario. Assume that you are a doctor in the emergency department. When one fine morning at 8 a.m. you receive a patient who was brought unconscious by the relatives. He had consumed some medication for his fever and cough, soon after which he developed vomiting, flushing, and then became sweaty and unconscious. The patient is unresponsive. He has central pulse, but brachial blood pressure is not recordable. Okay, so this is quite a serious patient who has presented to the emergency department. Having said that, this would be an approach. If a patient presents to the emergency department, or for that matter, if you see any patient outside the hospital as well, if you are a provider, first you check for the responsiveness. If the patient is responsive, there's a different algorithm to be followed. If the patient is unresponsive, next thing is to check for breathing. If the patient is breathing well, or the patient has an abnormal or absent breathing. These could be the two options. If the patient is breathing well, he should be put into recovery position to prevent aspiration. If the patient is having no or abnormal breathing, at this point you check for pulse, and this is a central pulse, that is carotid. Which side carotid? Any side would do, only for maximum of 10 seconds. It's recommended to check it for 5 to 10 seconds. If the pulse is present, mind you, the patient has an abnormal breathing, so you give the patient assisted breaths. If the patient has no pulse, so if there is no breathing or an abnormal breathing, you check for pulse. Which pulse? It should be a central pulse, which is carotid in adults. You check at any side, never both, as this may cause further cerebral ischemia if there is a pulse already. You check for 5 to 10 seconds, not more than 10 seconds. Now, if the patient has a pulse, mind you, the patient is an abnormal breathing, you need to assist the breathing. So you need to give assisted breaths. If the patient has no pulse or a doubtful pulse, start chest compression. This is an overall algorithm. To repeat once, you look for responsiveness. If the patient is responsive, you evaluate further. We'll discuss a lot about various patient presentations. If the patient is not responsive, you check for breathing. If the patient is breathing well, shift the patient to recovery position to prevent aspiration. If the patient has no breathing or an abnormal breathing, next step is to check for a carotid pulse. Mind you, this step is an optional step. Checking the pulse may even be excluded, and it has been recommended to be an optional step, at least for lay providers. For healthcare professionals, it's considered to be one important step. But if you have a doubt whether the pulse is present or not, you consider it to be absent. So if there is a pulse which is doubtful or absent, start chest compressions. If it is present, start assisted breathing. Right. So this is an overall approach as to how to go about a patient in the emergency department. The next concept is if the patient has a central pulse, but the blood pressure is not recordable, he's still unconscious. You'll start giving, assess the breathing part, which has not been done in this case initially. Assess the breathing, start assisted breaths and all, that would be required. But the important thing is that a concept of A, B, C's in the emergency department. So what is this? Let's speak something about that. So some of you may be wondering why ABCs. Some of you must have heard that it has been changed to CAB. So let's see what is the difference between the two. ABC, CAB. A stands for airway, breathing, circulation. Circulation, airway, breathing. So let's see how to go about it. So if the patient has a pulse, carotid pulse, as per previous examination pattern, you start off with ABCs. If the patient has no pulse, you start off with CAB, with chest compressions as priorities, followed by airway and breathing. Right? So this is the difference. So if the patient is in cardiac arrest, you start off with CAB. If the patient is not in cardiac arrest, it should be an ABC evaluation. So this is in short about how to go about it. Now, assessing the airway. So airway refers to the upper airway, which starts from the nose, mouth, the upper airway, oropharynx, nasopharynx, the pharyngeal part, larynx, and the upper part of the trachea. So this is how you assess. This is the assessment of the airway, which is followed by assessment of the breathing, followed by the assessment of circulation. Why is this order, so religiously followed? Because of the concept that treat first, what kills first. So the airway abnormalities or the threat to the airways would be killing first and earlier as compared to the breathing threats, which kill earlier as compared to the disability threats. Only when, I repeat again, only when A, B, C's are stabilized that you go to D and then E. D stands for disability. This is not orthopedic disability. This is neurologic disability. And E stands for exposure and environment. In trauma patients, there is one addition. With airway, there is also cervical spine protection. This is only for trauma patients, not for other patients or suspected trauma patients. Right. So having understood the initial evaluation concepts in emergency medicine for all the patients, let's see and address the questions. So this patient was brought unconscious, was vomiting and flushing, has a central pulse, and had consumed some medication, followed which all these things happened. So the patient had fever and cough. This could be an antibiotic and an antipyretic, analgesic. A lot of possibilities are there. Okay, so what would be the management priority? Oxygen by face mask is a part of breathing. As is the nature of medications, it would be detailed examination and history taking. Counsel the patient relative of the condition. This is an important part, but this has to be taken care only after the patient condition has been addressed, at least by some team member. Likely airway compromise. If you remember, airway is the priority and glucose. So this is a part of disability because abnormal sugar can cause neurologic disability. So the answer would be D. S is for likely airway compromise. Okay, coming to the next question. What can be the possible cause for airway compromise in this patient? As we have seen, after consuming some medication, patient has vomiting, has flushing, and the patient is unconscious, right? And the patient has shock. So these things qualify for presence of anaphylaxis. One other thing which comes to the mind is foreign body ingestion, aspiration. But this and this won't be a part of foreign body aspiration, right? So this is out. Retropharyngeal abscess is usually seen in children and young adult after a trauma directly to the posterior pharynx. Posterior pharynx or a spreading infection. Now, though the patient had fever and cough, immediately after taking some medication the patient deteriorated, which is not usually the time course for retropharyngeal abscess. So even retropharyngeal abscess is out. Lip and laryngeal edema can be seen in patients with anaphylaxis, but this is life-threatening. Lip angioedema may precede airway compromise, but itself is not the potential cause for patient's airway compromise. Hence the answer would be laryngeal edema. Okay. Coming to the next one, you could appreciate the tongue swelling and labored breathing in this patient. What would be the next priority, assuming vertical resuscitation? Now, so we have not discussed what is meant by vertical resuscitation. There are two types of resuscitation methods. One is vertical, another is horizontal. So if there are a lot of team members, one can take care of the airway, breathing, circulation, disability, history taking, etc. So all the things can be taken care of simultaneously, which is usually the scenario in functional hospital emergency departments, which are tertiary care. Vertical resuscitation, when there is only one provider, then he has to go sequentially from airway to breathing to circulation to disability. This is called vertical resuscitation. So there is a difference between the two. Okay. So if you are assuming vertical resuscitation, we have taken care of the airway, you see the tongue swelling now. What would be the next possible step? Okay, so giving fluids, no, this is not related to the tongue swelling. This is potential for airway compromise. So we need to do something about the airway. Blood sugar, no. Start oxygen by face mask, maybe yes, but not so soon. First we need to take a decision about tracheal intubation. Why so early? There's just tongue swelling because of anticipated collapse. As we'll see further in one of the questions, if the patient is going to have an expected poor course of airway compromise or otherwise, this becomes an indication for securing the airway upfront rather than waiting for airway to collapse and then going for a surgical airway. So taking the decision for tracheal intubation will be the next step. Okay, so what would be the most devastating adverse effect during or after securing the patient's airway? Well, all of these are potential airway threats. Airway bleeding, failed airway, and cardiac arrest. But obviously the most devastating would be cardiac arrest, which causes a lot of patient morbidity and eventually mortality can result from the same. Okay. Now, while you prepare to intubate for the patient, the nurse prompted that he could appreciate stridor. Initially there was only tongue swelling. You got ahead and tried to intubate prepared for the intubation. Now someone appreciates on your team that there is stridor. How may this information affect your decision? Okay, you proceed to take more detailed history. I don't think so. You need to act fast here. An additional history would not really help unless you're thinking for some foreign body aspirate. You decide to quit attempting intubation, which would not be a very wise thing because the patient has stridor, which suggests that the patient has worsened. You decide to start a drug antidote upfront. This does not seem to be a toxidrome or a condition which could be reversed by a single drug. So this does not seem to be right option. You decide to keep the surgical airway equipment and personnel on standby. This is a very important thing, and this is a very important part of one of the steps for intubation, which is called preparation and anticipating for failure. This would be a very important thing. So the answer would be to keep the surgical airway equipment and personnel on standby. Coming to the next one, which is the following patients is expected to deteriorate last while in the emergency department. Okay, so that once we have discussed the concept of treating first what kills first, so airway kills before breathing, which kills before circulation, and the disability abnormalities kill the last. Let's see. The patient in profound hypotension. This is a circulation issue. Unresponsive patient with vomitus in mouth. This is an airway issue because there is vomitus in mouth. Unconscious patient after being hit on the head by a baseball bat. So there could be an intracranial bleed. The patient is unconscious. There could be a potential brain injury. So this is a disability issue. Come to the last option. Bradycardic patients presenting with recurrent syncope. This is a circulation issue. Okay. Obviously, now since we have seen what is pertaining to what issue, unresponsive patient with vomitus in mouth is the one which would kill first. Yep. So coming to the next set of questions. So this is the case scenario. A 50-year-old hypertensive male presents unconscious to you in the ED after sudden severe headache and multiple episodes of vomiting 3 hours back, only 3 hours back. So quite an acute presentation. It's an elderly hypertensive male. There's no history of trauma, which is important. He has a patent airway, so you go by ABC approach. Again, his patent airway, respiration is 20, saturation is 90%, bilateral air entry is equal. So circulation, breathing looks fine. Airway looks fine. Coming to the circulation part, pulse rate is this. Patient has significant hypertension, so there is some problem here. Talking about the disability, the patient's Glasgow coma score is 7/15, which is too low. 15/15. You and me, while normally we have a score of 15/15. 7/15 qualifies by definition as coma, and the patient has equal pupils. Okay, so there is a lot of things going on. So there is a problem in the circulation, there is a problem in the disability. With what you can see here, with such amount of hypertension and unconsciousness, severe headache, man, there's a lot of things going on here. The patient typically has a raised ICP. The following statement is false. Patient does not need a supplemental oxygen prior to placing an ET tube. Okay, so let me discuss one concept which is known as rapid sequence intubation. First of all, clearly this patient is in deep coma. Anything which is less than or equal to 8 on GCS warrants an airway protection. Well, this is not a rule. This is a general guide. I would say it would be a guide, especially for trauma patients. This is among the guidelines. Even if this patient has stroke followed by raised ICP, this poor a GCS, unless the patient has had a seizure recently, which would be like rapidly reversible. If that is not so, the patient has such low GCS with this presentation, the first thing would be a decision to intubate. Though the airway is patent upfront, but since he has very low GCS, he has a risk of airway collapse. Why would it be so? A deeply comatose patient has decreased tone of the muscles of the airway and including the tongue, which falls back, occluding the airway. This is one of the reasons, rather I would say this is one of the most common reasons for airway compromise in patients with deep coma. Discussing what is known as RSI. So RSI refers to rapid sequence intubation. This is the method of choice for all emergency intubations. Why is it called so? Because the induction agent and paralytic agent are pushed in rapid sequence. You do not give any time between induction and paralysis, as is done in typical anesthesia practice while intubating. You induce the patient there, you bag and mask, and then you paralyze. This is not done in rapid sequence intubation or rapid sequence induction. Why is it so? Because most patients are not fasting. So this patient, the case which we are discussing, presented 3 hours after the event. He may have taken lunch before it. He would have taken some meals, some drinks before that. You never know. You don't know about the fasting status of the patient. Most patients in the emergency are not fasting, and still you have to intubate the patients. You cannot, you have to minimize the risk. I would say you have to minimize the risk for aspiration. And if you do some bagging and masking in positive pressure between these two, it would increase the risk of aspiration. So you do not do that. So you induce and paralyze rapidly, and then you place the tube in. Having said that, the concept of RSI is this. Now, what all does it require? So RSI has various steps which can be remembered in the form of P's, various P's. Now let's see what these P's are. How many have I written? 1, 2, 3, 4, 5, 6, 7. Okay, let's see. So one is patient. You have to understand what is the indication. You have to be sure and discuss it with the team members what the indications for intubation in this patient are. Next is preparation. You need to prepare the equipments, the personnel, the plan B. What if this plan fails? You have to do all the preparations. Right? Next is positioning. It's important to position the patient properly for a good intubation attempt. What is known as it can be, depending on the patient's anatomy, it can be at various positions. Usually the position which is used is called the sniffing position. There can be a ramp position as well if the patient is obese. So you need to position the patient properly. Then you pre-oxygenate. Then you push the induction agent. Then the paralytic agent. Then you place the tube, place the ET tube. Then you check placement. And then there is post-intubation care. So these are the steps of rapid sequence intubation, and they are to be followed in this order. Right? So let's see. Which of the following statements is false? Patient does not need supplemental oxygen. No, this is wrong. As we have seen that the patient needs pre-oxygenation, so where oxygen is used. There is a need to secure the patient's airway. That is true. Patient's airway need to be secured as the patient is deeply comatose, as we have discussed. Is likely to have raised intracranial pressure? Yes, very right. Drugs will be needed to facilitate the attempt of intubation? Yes, we need an induction agent and a paralytic agent. At least. There could also be a pre-treatment step, which is usually avoided in most cases, but this patient may need it. So the answer would be A. So pre-treatment, paralysis, tube position check, plan for failure. Are in these steps in progression? Okay, one thing which I missed telling you is here there could be an additional P for pre-treatment. So you first pre-treat, then you, first you plan for failure, which is very important, preparation and planning. Second, you pre-treat, then you paralyze, and then you check the tube's position. Okay, so this is 1 followed by 4 followed by 1, which is only in one option, which is this, 4 followed by 1 followed by 2 and followed by 3. Okay. Which of the following is the most common cause for airway compromise in deeply comatose patients? Thoracic muscles? No. Tongue falling and obstructing the airway? Yes. Inadequate respiratory efforts? Dyspnea is not an airway issue. This is a breathing issue. lower esophageal sphincter tone is decreased. This is true, but this causes aspiration, and it is not a direct cause for airway compromise. So tongue falling and obstructing is the right answer. Right. So coming to the next important thing in RSI is the choice of drugs. So the induction agent commonly used are ketamine, propofol, midazolam, plus minus fentanyl. And etomidate. Okay. So depending on the patient's physiology, either of these drugs is chosen for being used as induction agent. For ketamine, it increases the blood pressure pulse because it has catecholaminergic action. Catecholaminergic action. Okay. This increases the intraocular pressure as well. This does not increase ICP. This was considered as one of the teachings previously, but this has been debunked. Ketamine, there is no evidence that it increases ICP. It does not increase ICP. Okay. Propofol, it is cerebroprotective. Right? It causes hypotension and myocardial depression. This is a major concern, major concern in patients with propofol. A lot of patients go into hypotension, though it is maybe transient, but they go into hypotension and myocardial depression because of this. Etomidate, on the other hand, is very cardiostable. It does not cause any hypotension. It does not increase the blood pressure at all. It is cardiostable. There are some concerns with adrenal suppression here. That's it, right? So what our patient is like is that he has high blood pressure, is very high blood pressures, he's unconscious, has severe headache, so there is some neurotrauma going on, right? There is raised ICP. So you don't want to increase the blood pressure further. You wouldn't do that. If you keep it stable, well, fine. You will not crash the blood pressure, but that's not what we want. Rocuronium, on the other hand, is a paralytic. It's not an induction agent. It's a paralytic agent. The answer would be propofol, as this is also cerebroprotective. But you need to keep and check the blood pressures. So monitoring is very important in this. Now, you went ahead and tried intubating this patient. You attempted intubating, but could not succeed once. A call was sent to an expert provider who too could not maneuver the tube inside the trachea, which is the following statement is true. Okay, so as we have discussed previously, you need to plan for failure. Plan B. What would be the plan B? This is an important question. So if one is not able to do it, it's a good step to call an expert provider. If he is also not able to do it, we go for what is called as airway adjuncts. Use tracheostomy. Immediately, this is a surgical airway. Right? This is not the immediate next step. If the adjuncts also fail, you go ahead and do a surgical airway. So the airway adjuncts include bougie, supraglottic airway device, that is laryngeal mask airway, which is commonly used. This is a very useful tool and is very helpful in patients with difficult airways or planning for patients for failure. Okay, so use of tracheostomy immediately is not recommended. As such, also tracheostomy is not considered to be an emergency airway technique by many providers, as this requires some skills and has high complication rates. Instead, what we do is surgical cricothyroidotomy. The surgical cric is the surgical treatment of choice for patients with difficult airway or failed airway, not tracheostomy. Okay, airway protection is mandatory and one should continue efforts of per oral intubation unless successful. Well, this statement has 2 points. Airway protection is mandatory. This is right. But one should not continue these efforts forever, as this is not going to improve the patient's outcome. It's actually taxing the patient. Many times, and the number of times you do it, you're actually not inside the airway. The airway is still unsecure and the patient is suffering. So this is not the right answer. Use laryngeal mask airway as an adjunct? Yes, well, this is good, as this buys you some time, stabilizes the patient, and then additional steps can be planned, and this is a good adjunct to be used. Proceed to definitive management of underlying condition without wasting time. No, this is not right. Definitive management is only after an initial stabilization of A, B, C, D. I put a bar here because you proceed to D only after ABCs are stable. This is what is called as primary survey. Only after the primary survey has been completed and the patient's physiology been stabilized, you go for secondary survey, which includes elaborate history taking, which again has to be very focused, elaborate history taking and examination and definitive treatment.